So let's look at the scope of population health management. As we saw in the Partners Healthcare definition of population health management, which was a collection of activities not reimbursable in the fee-for-service model, but important in the care we deliver our patients, including primary care, specialty care, non-hospital care, patient engagement, and analytics and technology. Many are using the concept of population health management to refer to a set of components necessary to effect Jacobson and Tuch's definition of population health, which we said was a cohesive, integrated, and comprehensive approach to health, considering the distribution of health outcomes in a population, the health determinants that influence the distribution of care, and the policies and interventions that impact and are impacted by the determinants. Dr. John Glasser is a widely recognized informatician currently serving as Senior Vice President of Population Health at the Cerner Corporation and has a very distinguished history of employment, including being the CEO of Siemens Health Services, CIO and Vice President of Partners Healthcare System, Inc., and Vice President of Information Systems at the Brigham and Women's Hospital in Boston. I also note that he has served in several ethics departments of several of his employers. He has recently added specificity and elaboration to the Partners Healthcare list of population health components. Let's take a look at what he's talked about here. Key components, according to Dr. Glasser, include registries and scorecards, data warehouses and analytics for things such as total cost of care and utilization patterns, risk stratification and modeling, predictive modeling, disease protocols, clinical decision support, and outcomes management. Some additional components include care management, a longitudinal record, longitudinal care plan, and patient engagement tools such as patient portals, personal health records, social media, texting and email, telehealth, and mHealth. Now, Marshfield Clinic Health System in Wisconsin is another entity that has been a trendsetter for many years. Though headquartered in a town of just about 20,000 people in western Wisconsin, it is now one of the largest patient care research and educational systems in the U.S., with more than 750 physicians representing over 86 different medical specialties, more than 6,800 employees, and over 60 locations. Dr. Susan Turney is its present CEO. They were one of the first not only to adopt, but to develop and market an EHR. And they have been early adopters or innovators in ambulatory surgery, robotic surgery, hospital-sponsored health plans, and bundled payment contracting. Their experience in value-based care follows a systems approach, with the focus areas listed here. Let's take a look at these. There are 8 of them. 1. Define population, chronic disease at risk, surgical, medical therapy. Attribution, accountability, responsibility, who can engage. Identify care gaps, evidence-based care, care goals, care plans. Stratify risks, high, rising, low. Engage patients through portal, shared decision-making, education. Manage care through care plans, medication management, problem assessment, and observables. Feedback loop, population health, care reminders, decision support, workflow planner. And measure outcomes, utilization, satisfaction, quality, and comorbid events. Between these 2 thought leader lists, I've identified the topics highlighted and red that we're going to cover in the remaining part of this lecture and the second lecture in Unit 8. I believe we have addressed the other topics in previous units. I note that Dr. Glasser did not identify person and device identification explicitly in discussing the longitudinal record, but person identification is an important factor in achieving a longitudinal record, at least in a virtual manner. Both person identification and device identification have had recent breakthroughs and that we should cover here. I also note that Marshfield Clinic does not explicitly refer to social determinants of health as part of their factors in their systems approach to population health. This is very new, but also a very important factor that has at least been recognized, if not fully implemented, by thought leaders in population health. So our focus in the remainder of the lecture here and in the second lecture in Unit 8 will be attribution, stratifying risk, person and device identification, social determinants of health, and then in the next unit, engaging patients and care coordination. Let's first then look at provider/patient attribution/assignment. And obviously, by the number of variations, provider attribution, patient attribution, provider assignment, patient assignment, those are terms that haven't yet exactly been standardized. So certainly, we're going to settle on one for purposes of our discussion. Provider attribution is what we'll use for us for now. Health plans most commonly do provider attribution and may use the term member attribution over patient attribution when they attribute each member to a provider. Some health plans attribute patients or members to an ACO or other group of providers who have contracted with the plan and then leave the specific attribution up to the group. Whoever is conducting the attribution, it is done in order to improve management of patient care by virtue of the fact that every covered life under a health plan or every member of a population has a provider. This then makes it possible to tie quality and cost measures to a given provider, which ultimately forms the basis for analysis of total cost of care and outcomes in order to distribute shared savings, shared risk in a value-based care environment, and of course also to create a narrow network of providers for referrals. Today there are several ways provider attribution is accomplished with little standardization, which can lead to confusion for providers when each health plan with whom they contract uses different models. In general, though, a model is either retrospective or prospective. A retrospective model, or sometimes called a performance year attribution model, uses historical claims to identify patients in a provider's patient roster or panel prior to start of a defined evaluation method. Prospective or forward-looking attribution gives providers a list of patients for whom they will be responsible, often based on providers previously seen by patients. This model is becoming more popular than the retrospective model, which is actually the most common, because it is believed that a prospective model may be effective in capitation arrangements to drive change in individual patient care and can be patient or episode based. Now, in addition to whether it's retrospective or prospective, there are a variety of additional components to the attribution models, often a combination of the following. One would be single attribution, where again, either retrospectively or prospectively, patients are assigned to one provider, which may result in achieving the best accountability for patient care. Multiple attribution, on the other hand, again, either retrospectively or prospectively, assigns a patient to more than one provider. It is not common but may spread services or costs among providers more effectively. Majority attribution considers whether a patient receives more than 50% of care or costs from a provider, and plurality attribution assigns providers based on which provider has given the patient the most care among different providers. Now, obviously, the fact that these can be retrospective or prospective, single or multiple, majority or plurality, can be quite confusing, especially when any given physician or hospital or other provider who is engaging in value-based care has at least 10 to 20 different health plans, including CMS, that they're working with. So some operational challenges in provider attribution, and we certainly see a number of these. The following are some of the key issues. In thinking about this, I would refer us back to Unit 7, in which we looked at the medication management workflow. If you recall, there were several issues there, but the hospitalist who left the hospital's employment was actually the cause of the wasted nebulizer medicine, and certainly frustration on the part of the patient. While our focus in Unit 7 was on workflow interoperability, that case study was also an example of semantic interoperability from the perspective of lack of inaccurate provider data. Who is this provider? Where is he now? And policy interoperability, where there was no means to quote unquote cover for the provider who's sort of essentially missing in action. Improving provider attribution through addressing the following challenges could help many aspects of value-based care. First, inaccurate provider data leading to lack of accountability for patient care, such as we've discussed in Unit 7, could be improved by requiring use of the National Provider Identifier and discontinuance of the use of the Tax Identification Number, or the TIN, for billing, which precludes attribution of patients to an individual provider. Second, variation and lack of transparency in models used was noted on the previous slide, and is a matter that health plans could collectively address. Many health plans believe such matters as provider attribution is a proprietary right and competitive advantage, but it would seem to me at least to actually aid them in evaluating providers, and would certainly make distribution of shared savings, shared risk more equitable among providers. Patient churn in passive attribution contributes to poor care coordination. Today, many patients are not aware of the fact that they have been attributed to a provider. And sadly, providers today do little to educate their patients on the importance of having a primary care provider. Medicare estimates that as many as 40 to 60% of beneficiaries lack care coordination as a result. Think about again the workflow case study in Unit 7 on the patient who had a urinary tract infection, had a primary care provider, but also had an orthopedic, none of whom seemed to be coordinating that person's care across the different specialties. Lack of provider control over service population is another challenge. Providers often cannot control all of the services and spending attributed to them because patients seek care on their own with other providers. While patients should be able to seek care from any provider, they should be educated on the ramifications of what we typically call provider hopping. And finally, the inability to make comparisons across settings, plans, or providers is the result of the lack of a controlled environment where provider attribution is consistently performed with normalization processes to identify both providers and patients, which we'll talk about shortly, and where a central repository of patient data supports accurate attribution and can control for some patient churn. Several such controlled environments actually exist in some states, especially in Medicaid populations and across an integrated health system. But still, there are few of these and are insufficient to accurately make comparisons on cost and quality across the country. We've talked about provider attribution and the need for better data. We've said that patient identification was needed. We can also add device identification to that list of needs. Let's look at each of these. Provider data integrity is not just about the use of the National Provider Identifier, though that would help a lot. It is about assuring a level of standardization and provider engagement in keeping provider data current and accurate. The CAQH ProView is a voluntary effort that captures and shares provider self-reported data for more than 1.4 million physicians and other providers. CAQH is currently undertaking development of a provider data roadmap to standardize definitions and requirements, define and maintain high-quality data, and centralize data resources to help ensure that we can identify providers accurately, and especially for our provider attribution. Patient identifier to uniquely and accurately identify patients is perhaps one of the biggest issues in value-based care and even in healthcare in general, with patient matching issues and patient identity theft having been concerns for many years. A patient identifier was mandated by HIPAA, but spending money on creating the identifier was constrained by Congress due to privacy concerns. Finally, the 21st Century Cures Act and the 2017 Appropriations Bill enabled HHS to consult private sector groups to develop a national strategy on patient identification and patient matching solutions. One of the promising programs is a CHIME challenge to develop an accurate patient identification system for the United States, with challenge results due in November 2017. You might want to mark your calendar to see what they have come up with. And CHIME, of course, is the College of Health Information Management Executives. Unique device identification may not be as commonly recognized as an issue as patient identification or even provider identification, but can have significant ramifications in patient care and outcomes as implantable medical devices are increasingly being used. The Food and Drug Administration is creating a system of components to be phased in over several years through 2020. This will aid in device recalls and device quality and safety evaluation across the world.